Hi, my name is Yao, and thank you for joining me in this webinar on CALMIX. This lecture was originally presented and recorded at the Trans-Tasman Endodontic Conference in early June. However, we had technical difficulties resulting in poor audio recording. Hence, we are re-recording this segment of the lecture, and this will be uploaded for your viewing before we play the following segments from the recording at the Trans-Tasman Endodontic Conference. So the lecture outline for the entire series, we did break it up into 3 sections where we talked about the technology behind CALMIX, some clinical applications of how this material can be used in our day-to-day clinical practice, and as well as some future directions from what we've learned from this medicament and how we can use it to enhance our endodontic outcomes. So before we begin on what CALMIX is, I think it's a good idea to run through a brief history of what's actually been happening in the calcium hydroxide space. So back in 1838, Nygren was the first to use calcium hydroxide to treat dental fistulas. It wasn't really recorded very well then. It was just used, and it was used as a medicament to try and treat dental infections, dental fistulas. And it wasn't until 1920 that Herman, wrote a paper about it and introduced calcium hydroxide as a product that was sold in the market known as CALMIX to the dental market. And this product is still available today, although it's gone through a couple of reiterations, it's gone through a couple of modifications, but it still holds true to some of the original formulations back in 1920, which was more than 100 years ago. So fast forward to 1982, that's when Leonardo added radiopaking agents to these medicaments so that they actually show up on x-rays and we can actually see them in the canals and know exactly where we've placed them. And in 1991, Fava published a highly cited paper discussing various vehicles to slow down the release of hydroxide ions. So the whole idea was to try and reduce the speed by which all these hydroxide ions from the medicament were being released, thereby giving us a longer therapeutic window. But I think, it's been more than 30 years since since Fava really discussed the different vehicles, and it's really time for a change. So before we dive deeper into calcium hydroxide or CALMIX in particular, I think it's important to understand what are our endodontic goals. We do have to abide by some simple goals and rules for endodontic success. And I do like this statement from one of Sequeira and Rojas, one of their papers. It is right that the endodontic goal is really the reduction of the bacterial populations to levels compatible with periradicular tissue healing. And that is the primary microbiological goal of endodontic treatment, and especially in teeth with apical periodontitis. So we want to try and reduce the bacterial populations in the canal down to a specific level that our own immune system can sort of take care and prevent further infection. So why use an intracanal medicament? It's one facet of endodontic treatment. You have irrigation, you have canal preparation, you have obturation. All these different steps in the root canal treatment is to try and reduce bacterial load as well as to remove or prevent reinfection of the root canal system. But why are we using an intracanal medicament? Well, firstly, it's shown that there are many studies throughout the years, from 1991, even probably before then, right up to today, that shows that there's significant reduction in bacterial load after addressing the calcium hydroxide. That's because calcium hydroxide is a very potent antimicrobial. Furthermore, rotary instrumentation has also been shown to not contact all parts of the canal wall, because no canal wall is circular or geometrically perfect in shape. There's always a lot of nooks and crannies, lateral fins, isthmuses. It shows that that rotary instrumentation does not actually contact 1/3 of the canal walls. I mean, there are a lot of improvements lately to try and improve the contact of rotary instruments against the canal walls, different designs. But at the end of the day, you're never going to touch every surface. And as long as there's bacteria growing on the surface, there's a risk that the bacteria is left behind. And furthermore, we have histobacterial studies showing that intracanal medicaments have actually shown to improve bacterial reduction before obturation. And this is in comparison to this is in comparison to treatments where treatment was done without using any form of medicament, and it was done most likely in a single visit. So I do really like this this study by Vera, and Domenico Riccucci is the last author on the paper, and he does some excellent histological work. And you can see from these histological slides that's done in his lab, it shows that on the left side you've got the 1-visit group where root canal treatment was done in a single visit, and in the 2-visit group where an intracanal medicament, in this case calcium hydroxide, was used over a specific period of time. And you can see that there's a significant reduction in bacterial load. You know, on the left, when you have your 1-visit group, there's a lot of bacteria left behind in the canals, and in the 2-visit group, there's significantly less bacteria. And it's also very important, we can't clean these isthmuses. You know, it's almost impossible to instrument some of these places because they're too tiny for a file to reach into it. So it's very important that, you know, you may not be able to physically clean the bacteria, physically remove the bacteria, but that doesn't mean you can't use chemical disinfection to kill the bacteria. Because it's also been shown that, you know, even if there's dead bacteria there, but it's not, it can actually prevent apical periodontitis, even if you don't remove all the dead bacteria, as long as you sort of inactivate and kill it completely. So this is some confocal images from our research group up at the University of Queensland. And what we did was we used laser fluorescence to sort of light up endogenous bacteria. So in this case, you know, you can see in the isthmus area, these areas here are uncontacted by our rotary instrumentation. And because of that, you know, at a specific wavelength where the laser hits, it actually lights up and it shows that, you know, there's bacteria left behind that's not clean. And we'd expect that, you know, you'd instrument the canals itself, and the canal walls look very, very clean. But when you look at the isthmus area, it doesn't look very clean at all. And that's because you can't instrument these areas. I mean, you can use, and these are the times where you actually would use something like a chemical disinfection. And that's where your irrigations come in, your activation of the irrigations to agitate the fluids, or in most cases, calcium hydroxide. You leave it in the canal between visits, and that will slowly inactivate and kill the bacteria. Here's another example. You know, this is again a complex anatomy, and it's very unlikely for us to actually instrument these isthmuses here, and that becomes a challenge, and it leaves behind a lot of bacteria that could potentially cause persistent disease. So what we are dealing with are non-round canals, but our files are round. They generally cut in a circular motion. So we do have to find a way to try and kill bacteria, and as a complementary product to rotary instrumentation, and that's where I believe calcium hydroxide comes in. So there's always, there are two main groups of medicaments in the market today. You have your antibiotics and you have your calcium hydroxide that's being used widely as endodontic medicaments. So antibiotics, let's focus on that first. So antibiotics either inhibit the growth or reproduction of bacteria, which we call it bacteriostatic, and that will be your clindamycins, your tetracyclines, or you can have slightly stronger antibiotics that kill bacteria, and these are the bactericidal ones. And these are your penicillins, your cephalosporins, or metronidazole. So these are the different medicaments that actually kill bacteria. But either way, you know, there is a limited effect. Everybody knows that antibiotics, it kills bacteria discriminately. You know, you can build inherent resistance to certain bacteria, and antibiotics target selected bacteria. So you always have to pick the right bacteria, the right antibiotic that affects the correct bacteria. But that's hard to achieve because there are hundreds of different types of bacteria in the mouth, many of which we don't even know yet. You know, we haven't been able to culture everything. And I think in this era where we've got PCR and a lot more molecular techniques, we're starting to discover new bacteria that once wasn't, that we've never known before. And there's still many more that we don't know. So how do you choose an antibiotic that can specifically kill all bacteria? It's very difficult. And that's where calcium hydroxide comes in. Unlike antibiotics where it acts on certain bacteria, it kills bacteria indiscriminately. You know, the way it works with calcium hydroxide, it just exerts a very, very high pH. And this high pH breaks down cell walls, cell membranes, and because of that, it reduces cell growth, especially bacterial cell growth, metabolism. At the same time, you know, it works very well across the board on all different kinds of bacteria, whether they're aerobic, anaerobic, gram-positive, or negative. So that's why I think calcium hydroxide is a better medicament. And apart from just killing bacteria, there are other properties as well of calcium hydroxide. First of all, like I've mentioned before, there's no resistance to it because it just raises the pH. And when you've got a very caustic alkali environment, not many things can survive. It just creates a harsh environment for bacteria. So naturally, it's bactericidal. Because the hydroxide ions are very tiny as well, unlike large antibiotic cells, as well as different medicaments where you can have big molecules. These small hydroxide ions are very they're small enough to penetrate biofilms. And it's been shown that antibiotics doesn't really work very well in biofilm situations because it can't penetrate into the biofilms, and the biofilm is designed to fight antibiotics. Not to mention, because of the high pH, you do naturally have an antifungal effect, and that it just kills fungus as well. And studies have shown that during culture studies, they've shown that fungus is within the root canal system as part of the microbiota of the disease. Surprisingly, calcium hydroxide actually does have an anti-inflammatory effect. It is very caustic, but it can actually trigger certain interleukin pathways. So in this instant, lipopolysaccharides from anaerobic bacteria, gram-negative bacteria, generally triggers interleukin 1 and 6, and you have got your hydroxide ions that can actually stop the signaling pathway. Furthermore, it actually reduces localized inflammation because you're also inactivating a lot of the bacteria. You're providing a hostile environment where the bacteria can't grow, and the lipopolysaccharides don't exert an inflammatory response as well. So naturally, calcium hydroxide can actually immune modulate to a certain point that it reduces the effects of IL-1 and 6 and actually reduces overall inflammation. So there is an anti-inflammatory effect to it, but it is localized though. And finally, we can, to some extent, calcium hydroxide has the ability for hard tissue repair, and that's been used throughout the years. In open apex cases with wide apex, clinicians have been dressing the canals over and over again to try and induce apexification and closure of the apex before obturating the canal. So that's something that calcium hydroxide can play a role. And there's possibility that it's due to the availability of calcium ions. We still don't understand this concept very well yet, but we know that hard tissue repair is part of the process with calcium hydroxide, and we've seen that with apexification, as well as pulpotomy cases or pulp caps, where you've got calcium bridges forming underneath the pulp exposure point. So if we go back to the science or the background between calcium hydroxide and how it works, it's actually about the bioavailability of the hydroxide ions that provide the effect. So what happens is you may have a lot of calcium hydroxide in a medicament. The percentage doesn't really matter too much, because what's really important is you need the hydroxide ion. So unless the calcium and the hydroxide ions dissociate, you don't have the hydroxide ions available to raise the pH and exert an effect on the bacteria. So a lot of these water-based compounds, which is what calcium hydroxide is mixed with. So calcium hydroxide as a compound is mixed into a slurry or usually a paste of some sort, because it doesn't really dissociate much, given that water itself has a lot of hydroxide and hydronium ions. So you have this phenomenon known as the common ion effect, whereby you've got hydroxide ions from water itself, and you've got hydroxide ions from calcium hydroxide. So they sort of saturate each other to a point that you don't actually get a lot of dissociation from the calcium ion. So because of that, as you mix in a lot of calcium hydroxide into the medicament, into your solvent, in this case water, all you're just going to get is a paste, and majority of it is still remaining as a calcium hydroxide compound, and it just thickens up. So it's essentially when you mix flour in water, to a certain point, flour doesn't dissolve anymore, it just becomes a suspension. And that's essentially what's happening with calcium hydroxide. So, and that becomes, again, it becomes a significant problem, because when you have calcium hydroxide, pure calcium hydroxide in a water-based compound has a pH of around 12. But this is quickly buffered down by dentine, which is an excellent buffer. It was designed to buffer acid as well as base, and this quickly brings it down to a pH 9 or 10. And that really becomes a problem, because pH is a logarithmic scale. every step down is a base 10. So, you're going down a logarithmic number every time you drop one pH number. So that becomes a problem as well, because at pH 9 or 10, you're not actually killing a lot of bacteria compared to pH 12. So that's our enemy, Alkaline pH can disturb growth, metabolism, and cell wall integrity of bacteria and fungi. So a lot of studies have shown, especially this one by Chavez de Paz, has shown that the sublethal response for bactericidal effects is actually about pH above 10.5 for most bacteria. So without reaching anything above 10.5, sometimes these bacteria don't actually die off. They may go into a dormant state, but they can reactivate later on. And what happens is, these days, we don't have a lot of ways to show how well we kill bacteria, but there are a lot of conflicting ideas regarding bacterial studies, how well things kill, how well medicaments kill bacteria. But as a surrogate measure, that's all we have today. We can't be testing it in vivo all the time. But as a surrogate measure, it shows that pH 10.5 is what we really need to kill bacteria. And this is what's done on the benchtop. When you put it in the mouth and you put it into the tooth, you get all this buffering capacity, and that would greatly reduce this down to a point where you don't actually get too much disinfection anymore. Now, an even worse enemy will be E. faecalis. Again, Enterococcus faecalis is a bacteria that's found in a majority of the cases, both primary and retreatment cases. So it's not only a recalcitrant species, it's actually found nowadays with molecular studies. We found that E. faecalis has been found in a lot of teeth that require root canal treatment. And that's because they're very hardy bacteria. They contain a proton pump on the cytoplasm, which sort of acidifies it. So that allows it to maintain an acid environment and to prevent the high alkalinity from calcium hydroxide to actually break it down. So we actually need, it's one of the stronger bacteria around, and it's found that they can survive at pH up to 11.5. And that's very high, given that when you have calcium hydroxide in water, it's already at pH 12. If that gets buffered down by by the dentine, that drops down to a 9 to 10. And in that case, yes, it can still kill some bacteria, but E. faecalis, which is used as generally a lot of benchmarks for studies because it is a strong bacteria, and if you can kill this, you generally have a good outcome at killing majority of the other bacteria. But if you lower the pH to something like 9 or 10 after buffering by the dentine, you're not going to get a lot of bactericidal effect on Enterococcus faecalis, and that becomes a problem. And to compound things and make matters worse, bacterial infections, they don't just stay on the canal walls. They can actually penetrate into dentinal tubules, and these areas become very difficult to clean. And it's been found that bacteria can penetrate as deep as 200 microns into the dentinal tubules. So yes, your rotary files will cut to a certain extent, but nowadays we do try to prepare canals to a smaller size, but in the apical region, we don't prepare it as much as what we would do in the coronal region. So sometimes these areas, bacteria can still be hiding inside the dentinal tubule. So we do need a medicament that can actually diffuse into the dentinal tubules and create a very hostile environment for the bacteria to be completely eradicated. And just an example, this is what a dentinal canal wall looks like. You have, after EDTA is used, you remove the smear layer, you see all these dentinal tubules and these little channels as well. And it looks very clean and nice, but this is what an average size of a cocci looks like. So an Enterococcus faecalis, that's the size. It's a highway for these bacteria. So they can easily penetrate into the dentinal tubules and make its way into a certain point where it's difficult for us to eradicate the bacteria. So, it's found that, dentine tubule invasion ability of Enterococcus faecalis was markedly decreased under alkaline conditions. So if we dress with calcium hydroxide to create an alkaline environment, that actually prevents deeper penetration of bacteria between visits. So it goes to show that, at a pH of 10 and above, the mean penetration distance was a lot lower. So that's the reason why, compared to all these other environments. So definitely, if you want something to be even more improved, we try to aim for something higher. So in this case, you've got your high pH that creates a hostile environment that the bacteria cannot penetrate deeper. At the same time, you create a high enough pH to actually also kill the bacteria. So two effects: you inhibit growth as well as you're killing the bacteria. So in order for us to determine how we can design a new medicament, we went back to the drawing board and we looked at different alternative vehicles. And we found that when you mix calcium hydroxide into, as in the powder, into different vehicles, in this case, pulp dent paste, which is commonly used in Australia, it's a methylcellulose base, where it's actually a plant base. They mixed in 35% of calcium hydroxide in this entire medicament, and they found that they got a pH of 12.4. When we mix calcium hydroxide in water, you get naturally what's lime water. At a 40% concentration, it's 12.7. But we found that when you mixed calcium hydroxide into glycerol instead, at a 43% composition, again, the percentage doesn't really matter too much, because unless it dissociates, all it's going to do is just act as a filler and just be part of the medicament to make it gluggier and thicker. But when you mix it with glycerol, we found that there's a pH of up to 13, and in polyethylene glycol, which is a universal solvent for a lot of things, it's found in soaps, toothpaste, it's just usually used as a filler. We find that you get a pH of 15. But why is it different in these situations? Because when you put calcium hydroxide into water, you're expecting the compound to dissociate into your calcium and your hydroxide ions. But when you mix calcium hydroxide into polyethylene glycol, a different thing happens, because the polyethylene glycol molecule actually forms complexes with the calcium. So by binding with the calcium, you are releasing a lot of hydroxide ions. So every time the calcium is bound, it releases hydroxide ions. So there's an active flow, not just a mere simple osmosis effect whereby your dissociation of calcium hydroxide into its ionic state, because it's mixed into water, and you've got that common ion effect I discussed earlier. That's what's limiting the amount of pH available, because it's your hydroxide ions that provide the pH. But with the polyethylene glycol base, you actually get an active removal of, or actually an active process where the calcium ions are actively moved out from the compound, and that releases the hydroxide ions. So naturally you get a much higher pH. And again, a pH of 12 to 15 is a significant difference, because every pH increase you go up is 10 times more, because it's a logarithmic scale. So by going from 12 to 15, you're naturally going up almost 1,000 times. So that is CALMIX. So CALMIX is a medicament where it's got calcium hydroxide based on a polyethylene glycol vehicle. So some of the early studies that were done, titration studies using hydrochloric acid to try and challenge the neutralization of hydroxide ions, they found that with polyethylene glycol, especially PEG 400, and 400 just means the molecular weight, because you can have PEG at different, slightly different variations, there was significantly higher hydroxide ion release compared to calcium hydroxide when saturated in water. And that's not surprising, given that all the calcium hydroxide compound in water remains as a compound, as a filler particle rather than as ions. So the technology behind CALMIX has actually been patented in Australia and around the world, and it was actually developed right in our own backyard. It was developed by Australian dentists, in this case, Professor Laurie Walsh and Dr. Basil Athanasiadis. So where I come in is I did a lot of the lab research as a research student under Professor Laurie Walsh, and that's how I got involved with this medicament. But this material is patented by Professor Laurie Walsh and Dr. Basil, and they're starting to get patents all over the world for it. And it goes to show that the medicament is accepted, and we are trying to promote this as a medicament, because not just based on what it can do, but we're trying to improve the outcomes, and we have the science to back it to show that this is a good medicament. And the lab studies, we did a lot of the lab studies ourselves in the University of Queensland, and it's shown that it's got significantly higher disinfection properties compared to other medicaments in the market today. So the technology behind CALMIX is very simple. CALMIX uses a special copolymer of polyethylene glycol. In this case, it's PEG 400 and PEG 3350. So they're just different molecular weights of PEG, and it was formulated to give the most optimal hydroxide ion dissolution which means into its ionic forms and as well as release, so that it's bioavailable and it can actually do its job by raising the pH and killing bacteria. Majority of medicaments in the market today, in the Australian New Zealand market, use water alone. In this case, something like Calisep, where it's actually a saline composition, or in combination with polyethylene glycol. So some medicaments were using polyethylene glycol, and this goes back again to the paper I talked about earlier, Fava in 1991, where they were actually using PEG because it's a slightly more viscous medicament vehicle, and their thoughts were to reduce the flow, because if it's water, it gets washed out really quickly. By using some sort of a viscous vehicle, you slow down the release of calcium hydroxide and you get technically a longer therapeutic window. But they didn't actually discover the effects of polyethylene glycol on how it can change the way we do things, or the way that the chemistry behind calcium hydroxide, and how it can actually improve the pH levels as well as the dissociation. And that's all part of Professor Laurie Walsh and Dr. Basil's initial patent on this product, on why calcium, or why polyethylene glycol should be used as a vehicle, and the science behind it. So we did publish a couple of studies, and but before we dive into the studies in detail, I'd like to go through some of the common medicaments that are available in the market today. So you've got Pulp-Den, which is mainly a water-based. It's got a couple of thickeners with methylcellulose, which is a plant-based medicament. So it is biocompatible, but it is still, the vehicle is mainly water. You've got Calisep, which is an isotonic saline, but CALMIX has no water in it. It's just purely polyethylene glycol, which is a universal solvent. But by removing water, that doesn't limit us to a pH of 14, because 14 is generally, which is what is commonly known as the upper limit of the pH scale. That just means how much hydroxide ions is in a specific solution. In this case, when it's measured using water, we know that it's up to 14 as well, because that's the theoretical limit you can dissolve into water. Anything more than that, you can't achieve because of the common ion effect. There's hydroxide ions in water as well. And lastly, you've got Odontocide as well, which is a 20% composition, but it does also have ibuprofen and polyethylene glycol mixed with water. So the ibuprofen, unfortunately, that's a bit acidic, so that actually does bring down the overall pH, as well as the water in the composition does reduce some of the pH as well. So when we look at the different compositions, again, Pulp-Den and Calisep, they generally give us a pH of 12, and that's expected, given that we have the theoretical limit for calcium hydroxide mixed in water is generally around 12 to 12.5. But when you have your PEG-based stuff like Odontocide, that gives us a slightly more than 12, and that's because it's, again, although it's PEG-based, it's mixed with water and a little bit of ibuprofen, but in CALMIX, it's purely just polyethylene glycol. We get a pH of up to more than 13, in this case 14, and in certain cases even up to 15, just depending on the composition that we have. And this study was done using two kinds of electrodes, because at first we had some issues with electrodes, meaning that the original electrodes were used to determine hydroxide ions in a water composition. So we actually tested it using two different kinds of electrodes, one designed for water-based compounds, one designed for non-water-based compounds, in this case, polyethylene glycol. And we can see even in both these electrodes, we find that there's an increase. And what's really surprising here is at 38% composition of calcium hydroxide in Pulp-Den, you get a pH of between 12 to 12.5, just a little bit more than that. Again, with saline and Odontocide in PEG mixed with water, you get a little bit increase. But it's just really interesting that even at 5% calcium hydroxide, so you don't even have to go up to 40%, at 5% in just pure polyethylene glycol, it's already showing more more hydroxide ions and a higher pH. So it goes to show that all the remaining calcium hydroxide in all these water-based compounds don't actually provide any effect. It's just acts as a filler for the medicament. So if you mix in a lot of calcium hydroxide, it just becomes a paste rather than a slurry or a solution. It just becomes thicker and thicker every time you mix in more calcium hydroxide, but it's not actually available for use. So it goes to show that in CALMIX, by the time you reach up or if you mix 40% of calcium hydroxide in polyethylene glycol 400, you get a very high pH, almost touching 15. And the reason why we used a copolymer is because we found that even at 37.5, slightly lower than 40, we get a higher pH because of the synergistic effect between the two different molecular weights of polyethylene glycol. So in order to quantify all this, or to make it in a simple way for us to visualize how well this medicament works, we used a very simple high school experiment where we used red cabbage dye. Red cabbage dye has been used historically as a pH indicator because at different pHs, it shows different colors. So at a very acidic pH, it appears very red. And as you get to the neutral area, it usually appears purple or bluish. And as you get to the alkaline range, it gets really yellow. So it forms a very good marker for us to determine whether the medicament is actually, we can see what pH the medicament is. So that's what we did. We made different compositions and we only focused on obviously the alkaline range. And we found that between pH 8 and 13, we found different, we actually found different color changes. So in order for us to track this digitally, what we did was we looked at the digital color of these individual vials and we sort of measured the channels of the different colors. So every color is made out of usually 3 different colors. I mean, traditionally we know it's red, yellow, and blue. But in the digital space or in computers, it's generally RGB, which is red, green, and blue. So when we looked at the amount of red in a specific color, the percentage of green in a specific color, we looked at the pattern and we noticed that, we use this as a surrogate measure or as a benchmark. We find that as you go up in pH, you also go up in the amount of red and amount of green in a specific color. So the percentage of that color. So that sort of gives us a way of reading or quantifying something in a tooth so that we can track the visual changes in the tooth to determine as the tooth gets more yellow. And if we actually track it and we break down that color and we look, if there's more red or green in that color, we know that the pH is increasing. So that allows us to translate this into a tooth model where we actually stain the tooth. And that's what you see on the top. That's actually a really, really heavily stained tooth in red cabbage dye. In this case, in the neutral pH, it provides a purple environment, but it's a very, very dark purple here. But as we've left CALMIX into the tooth, we can see that it starts to diffuse out into the dentine and it forms this sort of ring barking effect as it penetrates into the dentinal tubules. And you can see that at a yellowish area, we know that that's very high pH out here, slightly less pH here. So again, when we take away all the background and we just focus on the tooth itself, just in 2 weeks, you can see the significant change with the inner dentine, where again, bacteria penetrates from the canal walls in. We can get a pH pretty much 13 to 14 in these regions. And even in the outer periphery, you're still maintaining a pH of about 10. So using this method, we could actually visualize what's happening in these roots over time. And we found that as time went on, after 1 week, you see a little bit of a change in the inner dentine. After 2 weeks, it gets a little bit more profound into spreading out to the outer dentine. And it's at about 3 weeks, it sort of stabilizes at that point. So it gives you a very good effect and a very good disinfection effect in the inner dentine, which is what we want. That's where the bacteria is. But at the same time, we're also penetrating out. When we look at a water-based compound like Calicept, again, we stained the root and we left it over the course of 3 weeks. And you find that at 3 weeks, only a very small area in the inner dentine shows a slight change towards the yellowish range. So we know the pH is definitely not as high as CALMIX. And not much has changed beyond 3 to 5 days, right up to 21 days. So it provides a lot of effect very early on, but it doesn't really improve over time. And that's because of a water-based compound. Again, water is less viscous, it flows through really quickly, it provides its effect, and there's always that possibility of a relapse happening. So we didn't see this in our study because we only left it for 3 weeks, but when we quantified it, we did actually see some changes, and we'll get to that in a second. And just so that we know that it's got nothing to do with the PEG alone, we did this as a control with just pure PEG, and there was no changes in the root color over 3 weeks. So this is what we've done. We looked at the color changes at different points at 250 microns, which is a good point to measure. That's where we think the bacteria will will go. Remember how bacteria can penetrate up to 200 microns. And we also tested at 500 microns, just in case there are bacteria that decides to make its way further out. We found that there's no significant color change to show from baseline. That means we don't really think there's a significant color change to show some sort of profound effect in caliceps until about 3 weeks later. And it's only in the inner dentine. In pulp dent, you can see this effect happening very quickly at 1 week, because pulp dent is with the methylcellulose and a higher calcium hydroxide content. It does generally provide a better effect. But in the 500 microns, it only started to give you a profound effect after 2 weeks. But in CALMIX, you see this effect happen at 1 week, right up to the 500 microns, which is pretty much to the outer dentine already. And it sustains this throughout 3 weeks. And odontocide, again, you have a very good effect because odontocide is PEG-based, but because of the water that's mixed in together with ibuprofen that's acidic, it generally relapses after 1 week. So it's sort of like a wave effect. It goes out to 250 microns, then it gets buffered, and then it goes up to 500 microns and it gets buffered after that. So it generally loses its efficacy after a certain point in time. And in this, one of these classic studies done back in 1993 in Melbourne, we see that, yes, you get this big change in rising pH, but then it drops very quickly after. So in a span of 1 to 3 days, that drops down. And is that enough to kill the bacteria? That's what we have to really worry about, because is that sufficient enough to kill the bacteria? And how this study was done was a tooth model where small cavities were drilled from the outside of the tooth, one shallow, and pH electrodes were placed in these cavities to measure the changes in the pH in these areas. So obviously the shallow cavities were to measure the outer dentine, and the deeper cavities would measure the inner dentine. And they were repeated on coronal and apical because of the different dentinal tubule amounts and size in the different dentines between apex and coronal dentine. So when we can see this study was done in 1993, in 2018, the group out in Western Australia repeated this similar study, but included CALMIX as well. And they found that in the inner dentine, at 7 days, CALMIX had a significant rise in pH, and this dropped off fairly quickly. It sort of sustained for a little bit, but it reached about pH 11. And again, the cavity may not have been drilled right to the absolute canal wall, but just probably a couple of millimeters in. And it sort of sustains that above pH 10 right up to 1 and almost 2 months. But all the other medicaments pretty much got up to about pH 9 and sort of tapered off from there. And we know that you need something more than 10.5 to actually predictably kill bacteria. And in Enterococcus faecalis, you kind of need something more than 11.5 to be exact. And when we look at the outer dentine, which is the bottom graph, we find that it does take a little bit more time to reach its maximum potential, and it doesn't really get as much as high a pH because a lot of it gets buffered by dentine. We can see that at 1 month or 4 weeks, it reaches its peak and significantly higher compared to the other medicaments that were tested. In this case, caliceps or CALMIX mixed with lead mix in this to try and provide some antibacterial, some anti-inflammatory effect, because lead mix is an anti-inflammatory agent. It's got steroidal agents in it. So we can see that in these areas at one week, that's where you get your peak performance of CALMIX into the dentine as the peak pH, and that sort of correlates to a study that was done just over 30 years ago as well, that showed that 7-day dressing effectively eliminated bacteria which survived biomechanical instrumentation of the canal. So I would say that's sort of the minimum requirement that I would leave the medicament in the canals for. I generally medicate the tooth for about 1 week at the very least, but majority of the time even longer than that. So think of the 1 week mark as the minimum. Anything more than that is a bonus. And we know that CALMIX can actually provide a therapeutic effect for up to 3 weeks. And the other medicaments, they tend to lose their efficacy after 1 to 2 weeks. So just don't take our word for it. I mean, yes, I don't have any financial interest in CALMIX, but I did do some of the research. And again, just because this is going to market, we actually did do a lot of studies done by independent labs, and it's found that, PulpDent and CALMIX have very good ability to kill Enterococcus faecalis, but do bear in mind this was all done on a bench top, so it was pretty much putting the paste straight onto lab-grown bacteria. There's no dentine to buffer anything. But what's really surprising with CALMIX is that it actually kills Candida albicans, which is a fungus, significantly more compared to the other medicaments in the market, such as PulpDent or Leathermix. In this case, is used more as a control because it's an antibiotic steroidal cream, or just peg on its own. And when we look at the antimicrobial testing as well, where again, these were all done by independent labs, it found the amount of remaining bacteria that's surviving was very low for CALMIX, Calicept, and PulpDent because of the effects of because of the antibacterial or antimicrobial effect. But for fungus, only CALMIX was really effective than all the other medicaments in the market. So it goes to show that Odontocide, even though that's a PEG base, is not very effective against Enterococcus faecalis because of the ibuprofen that was placed in it and the water that significantly reduces that pH. It's very critical that you have to reach that above that pH 11.5 to predictably kill bacteria, or in this case, Enterococcus faecalis. And again, to reiterate, these were all done on benchtop studies. The tooth model is a lot harsher. You have dentine, you've got nooks and crannies where you can't actually physically debride. You've got biofilms there. These are just testing on one bacteria. So we've had a lot of questions actually on the biocompatibility of polyethylene glycol. And we know that polyethylene glycol is used extensively in the pharmaceutical industry. As I mentioned before, it is non-irritating to skin. That's why it's being used in a lot of soaps. It's being used in a lot of lubricants. It's been used in toothpaste. It's generally used as a filler. It's used in the cosmetic industries for a lot of moisturizers, creams, makeups. And it's generally approved by FDA for internal consumption. You can actually ingest this safely without causing any issues because it is it's food grade to a certain extent. So again, we did independent assays of CALMIX, and this was all done by independent labs to show that CALMIX has proved to be less cytotoxic than reference samples of PulpDent and Ultracal. So despite its higher pH, it's actually less cytotoxic to tissues, surrounding tissues, and these were again done on cell lines and lab-grown tissues. It was less cytotoxic compared to PulpDent and Ultracal, and the reason why is because although it provides a high pH, a lot of times the CALMIX is not actually exerting the effect directly on tissues. It's actually releasing the hydroxide ions that gets mixed in with the interstitial fluid as well as the fluid within dentinal tubules, and it just maintains that high pH of 14 or the maximum limit, or maybe even 12.5, but it keeps it at that 12.5 point. So even though the medicament itself can be 15, it actually releases the hydroxide ions and it actually provides that effect at the maximum theoretical pH when it's mixed in with water at 12.5, and that gives you that effect, and there shouldn't be any difference in the cytotoxicity, but in this case, it's even less cytotoxic. So that's a very important thing about this medicament, and we can show that you can safely use this. I mean, obviously, if you extrude it out the apex, it's going to be a little bit tender to tissues because of the high alkalinity, as with any other calcium hydroxide medicament. But it's, again, an independent lab has shown that it is less cytotoxic to cells, as in body cells. Radiopacity is another thing that I do like about CALMIX, is that it's got very, very high radiopacity compared to the other products in the market. You've got Ultracal, which is also very highly radiopaque. You've got PulpDent as well, and that's usually because a radiopaquing agent is placed, but Odontocide doesn't seem very radiopaque, most likely due to the composition, because it's got a bit less calcium hydroxide in it and probably a bit less radiopaquing agent. CALMIX uses zirconium dioxide, so it is a zirconium dioxide and I think barium sulfate, and that allows us to provide a non-staining radiopaquing effect. So unlike in the past where other radiopaquing agents such as bismuth were used, by using zirconium or barium, you don't actually provide, it doesn't actually stain up teeth. And why I do like radiopaquing agents or something that lights up really well I use it very often when I prep a tooth, and sometimes if I'm not sure about the anatomy of the tooth, a good trick that I use is I actually put calcium hydroxide into the prepared areas, and I take a cone beam, and that allows it to light up on the cone beam to show me sort of like the pattern of the canal morphology very clearly. At the same time as well, I can see it in the canals on PAs. Usually there are times if I'm afraid that I might have extruded something, I take a PA and I can see if I've extruded any medicaments or how much calcium hydroxide I've placed into the canals, if there are any voids, bubbles. And, in the molar, it may not be as critical, but sometimes it is very important for apexification cases. You want to be able to see the calcium hydroxide contacting the apical, the apex of tooth in open apices cases. And that's how you're going to get your apexification apexification effect. So just to switch gears a little bit now, let's talk about the calcium ion. We've been focusing on the hydroxide ions from the very beginning of this webinar, but we haven't actually really discussed where the calcium comes in. So calcium as a whole is sort of forgotten as part of the calcium hydroxide. In the CALMIX realm, it's bound to the peg and we forget about it and we focus on the hydroxide. But is there really a role for calcium? We're not sure yet. The exact role in endodontics is relatively unknown. It is believed that calcium can form calcium carbonate from calcium from carbon dioxide. So when you have certain cells, aerobic cells, can release carbon dioxide. Also, when you've got caries where there's exposure to the oral environment, you've got carbon dioxide, it can actually form calcium carbonate, which is like a little hard substance. And, that can actually reduce the amount of calcium dioxide in the entire pulp or in the entire necrotic tissue. And by reducing calcium dioxide, which is an acidic compound, you actually change the environment for bacterial growth. So by taking away some of the calcium dioxide mixed into water in fluid, in this case, think of it like soda water, which is essentially calcium dioxide bubbled into water to give it that effect, and it's generally acidic. So by removing calcium dioxide from the necrotic tissues, and the necrotic pulpy tissues are in the canal, you change the environment and you could actually theoretically lower bacterial growth. But there's a very interesting paper that's recently published just about 2-3 years ago that shows that an influx of calcium ions into epithelial cells can actually activate certain pathways that result in the breakdown of these cell cyst linings. So again, it's just very rudimentary studies at the moment, but it does show that calcium hydroxide can provide the calcium ions that could theoretically be used to break down the cyst linings. So in cases with large periapical lesions, again, we don't know if they're cystic because you have to do a histology test in order to determine if something is cystic. It wouldn't hurt to actually provide calcium hydroxide into large lesions for a lengthy period of time. So there are times with very, very large lesions, I do try to medicate it for a slightly longer period of time, maybe 3 or 6 months, and potentially, you provide a very hostile environment for bacteria to grow. It gives us time to track to see if the lesion changes in size. But there are some thoughts that the calcium ion as well can play a significant role in the breakdown of cyst lining. So again, this is very, very early studies, but I would say I'd like to watch this space, and potentially there'll be more studies coming out in future on how calcium hydroxide can improve the outcome of long-term big lesions such as cysts and all that. So that's something that's very interesting, and I think that would reduce the need for apical surgeries at times, but also as a whole, it will improve the outcomes of endodontic treatment. So calcium ions as well, we've known this for a while now, and that's going back a long time. About 40 years ago, there was a paper that shows that hard tissue bridge composition contains calcium ions from the pulp capping material. So in the past, when you had pulp exposures, they were pulp capped using calcium hydroxide. And in this day and age, we use MTA a lot for pulp caps, but MTA is essentially containing calcium hydroxide. Calcium hydroxide is released as a byproduct. And they found that in the hard tissue that's formed underneath the calcium hydroxide, where you've got your dentine bridging to sort of seal off the exposure, they found calcium in it. So where is the calcium coming from? It has to come from somewhere. it's unlikely to come from the pulp. So most likely it's actually provided by the calcium hydroxide itself, in this case, the medicament. So to reiterate the benefits of a non-aqueous calcium hydroxide, and in this case, CALMIX, which is completely non-aqueous without any water in it, it has a longer lasting effect. It maintains a higher pH compared to other medicaments. And it's got deeper disinfection of dental tubules. And we've seen this with all the red cabbage dye studies that we've done. But again, back to this confocal image again, I like to see it makes me think as a clinician, as an endodontist, where we do root canals all day, we want to be able to predictably clean the isthmus areas. And we know that our instruments are never going to contact these areas. We need something a bit more. Yes, you've got different activation strategies today, but sometimes the simplest things, such as leaving a medicament behind to actually chemically disinfect the canals, can work just as well and a lot more economical. So not just the theoretical or the science behind CALMIX. What I personally like as a clinician today, I need a medicament that works well in my hands. It improves our outcomes, but also improves our ability to provide treatment on a day-to-day basis. And I've just picked up some of the handling properties which I really like about CALMIX compared to other medicaments. First of all, it does not dry out because there's no water in the compound. It doesn't actually dry out. And if many of you have used medicaments such as pulp dent, they tend to crust up a lot. And I have no idea how many pulp dent tubes I've wasted, because every time I try to squeeze out that little crusty bit on the top, half the tube goes flying across the room, and you've just wasted half the tube. Not to mention they dry out fairly quickly and you have to replace the tubes very, very often. But with CALMIX, they generally have a longer shelf life because there's no water in it, so it doesn't dry out. Because again, it doesn't clump up, unlike pulp dent, which uses methyl cellulose, which is a very clumpy, gluggy material. It flows better into narrower tubes. So we can actually use this really, really narrow tubes that allow us to place them into the apical thirds of the root canal, which is where we really want them. That's where you can actually kill all the bacteria in the apical dentinal tubules, which are a lot finer and smaller. It's got improved radiopacity. I've discussed that earlier on how that's better for me to see if I've extruded anything, as well as to help me identify anatomy if I take a cone beam. And finally, it's also easier to remove. And this has been shown that, pulp dent, when mixed with carboxymethylcellulose, the plant-based material, which is very gluggy, it tends to clump up. It's actually very difficult to remove the canals. But because CALMIX itself, it's a medicament that's, it's got polyethylene glycol, which is a universal solvent per se. It actually forms, it actually breaks down really easily when you try to wash it out. Because as a universal solvent, just because there's no water in it doesn't mean it can't dissolve in water. It is still water miscible. So that's one of the, these are the 4 key areas which I really like about CALMIX for my day-to-day practice, aside from obviously the improved disinfection. And that's where I think it's really helpful in the clinical environment. So to recap everything, you've got CALMIX, which has an enhanced and prolonged disinfection. It's got deeper penetration into dental tubules compared to other medicaments. It's easily introduced. And again, these are the little tips I'm talking about. You can actually place these tips right into the apical third where it matters most. All these are optimized viscosity for delivery through these tiny tubes. And there's no way, I've tried them myself, you can't get certain medicaments which are gluggy through these very, very thin tubes. So that's essentially a edge or flowable tip with an even smaller lumen fishing line consistency, but it's a tube for the medicament to flow, and that allows it to snake down curved canals and into lateral fins and all that. And finally, it's easier to remove, but most importantly, it's also a very economical way of providing disinfection without having to dive into expensive gadgets to disinfect, such as activation instruments like lasers or ultrasonic tips and everything. I think CALMIX is really a quick, effective, and affordable way to actually improve your disinfection of root canal treatment. So this is CALMIX. These are some of the advantages, again, reiterated, and it is a good material. I've used it for the last couple of years, and I find that, I'm really surprised at some of the lesions that have healed up. Some of them I really think that, I'm probably looking at surgical treatment down the line, and when I review these cases, they've healed up really, really well. So I like to believe that, the science does back it up to show that it does have improved disinfection. But as a clinician today, predominantly, I do like the handling properties. It does make my life easier. So this is the end of the first part of the webinar. The future segments of the lecture that was recorded at the Trans-Tasman Endodontic Conference will be presented at a later date, but this is just a recap. The other segments, I believe, were recorded at a much better resolution and better audio quality, but we will see, and then we will see you next time for that. So thanks again for joining me, and if you have any questions, by all means, feel free to email us or email Osden, and they'll be more than happy to forward it through, and I'll try and get back to you. Thank you.